Hello, I am Dr. Julie Koda. I'm a chiropractic neurologist, and this is Merck, Chapter 184, talking about demyelinating diseases. So in the introduction here, this is a copy and paste of the Merck manual here for you to read. And what I want you to look at here, and we're going to be talking about myelin sheath and what that's made up of, and how to kind of maintain nice, healthy myelin sheath and hopefully to repair, rejuvenate myelin sheath. But I want you to look down here at the third to the bottom. Okay, so I'm going to read these couple of paragraphs here for you because they're extremely important to note here. So the Merck is an allopathic medical textbook. It is industry standard medical doctor text. Okay, so let's think about that while we're reading this. Demyelination is often secondary to an infectious, ischemic, metabolic, or hereditary disorder. In primary demyelinating disorders, cause is unknown, but an autoimmune mechanism is suspected because the disorder sometimes follows a viral infection or a viral vaccination. And I highlighted that so you could see that and take note of that. And at the end of this chapter, the Merck denies that vaccines are irritating to demyelinating disorders. So it's flat out contradictory to each other. And we'll get to that aspect when we see that. I just want to point it out here. This is exactly how they start. This is the introduction. Okay. Then the next paragraph here. Demyelination tends to be segmental, patchy, affecting multiple areas simultaneously or sequentially. So of note, multiple sclerosis, that's the main demyelinating disorder, right, that we think of. And it just means multiple sclerosis being plaques, lesions, scars. Just think of them as scars on the central nervous system. It doesn't actually tell us what caused it. That's our job. We need to get to the root of the problem, figure out what the cause is, then we can find the cure is how we say it, right? Find the cause, find the cure. So we don't really talk about cures with this because we can get ourselves into trouble there. But if we look at the root problem here, we can better treat it. Okay. We need to find the offending factor, address that, and then hopefully repair, regenerate, and recover. Okay. So sometimes it's a gluten sensitivity gone haywire, and that can cause demyelination and multiple sclerosis looking plaques in the brain. So it could be something just as simple as that. Okay, so a leaky gut system happening, okay, and gluten irritations. How easy would that be to fix, right? We want the easy fixes here, and we want to be able to find those quick root problems there, and then coach and help the person repair from it. Okay, could be a whole lot more complicated than that. So at the last paragraph here highlighted, remyelination often occurs with repair, regeneration, and complete recovery of neural function. However, extensive myelin loss is usually followed by axonal degeneration and often cell body degeneration. Both may be irreversible. I need you to read that highlighted version. Okay, go for the hopeful line here. Remyelination often occurs, often. Okay, the other part here, okay, this might be when we don't find the causative action, right? We don't find the offending factor that is causing the demyelination. So how do we expect to heal from it if we keep slamming our hand in the door? How are we going to heal that hand, right? We need to figure out what that causative action, that offending factor is. And then we'll see what it's going to take to repair, regenerate, and get a complete recovery. Okay, so I want you to be able to know that these are the Merck's words exactly, verbatim, quote Merck. Okay, so this is, we know that this is true. A little review for you here on white matter. So what makes white matter white is the myelin sheath. The cell bodies are in the gray matter, remember. So our mnemonic here for what cell type is making myelin in the central nervous system, okay, is the oligodendrocyte. In the peripheral nervous system, it's the Schwann cell. So we go for the mnemonic COPS, central, oligo, peripheral, Schwann. Okay. And we now know what these words are here, right? So you saw this in neuroscience. This is just a review slide. So in the central nervous system, when we're talking about white matter, we're looking at fasciculus, funiculus, lemniscus, brachium, peduncle, columns, like our dorsal columns, right? But most commonly, we're going to see them as tracts. We're just going to call them tracts throughout the cord, right? So now we want to think of these, any of these areas here are going to be subject to demyelination issues, right? So then look here at the commissures. So commissure, association fibers, and projection fibers. So commissures are going to connect the two hemispheres of the brain. So think corpus callosum, okay? And this is white matter. So if we see white matter demyelination in any of these areas, you can then kind of figure out what the signs and symptoms would be. Okay. Association, connect regions within the same hemisphere of the brain. We can see problems here as well. Projections, connect one brain region to another or to the spinal cord. Again, all of these areas can be subject to demyelination or multiple sclerotic plaques. Another little review slide here. Any of these reviews that you need a little bit more of, feel free to just pause and read. This one's a good one, right? So just note how it kind of wraps around the axon here in this kind of jelly roll-like fashion. So here, remember, we want to be able to see this regeneration of a nerve fiber. Now, this is specifically the peripheral nerve. Okay, this is specifically how we know it's done in the peripheral nerve. The central nervous system is a little bit more mysterious, okay? But if we can figure it out in the periphery, we can make some hypothesis on how and what is happening in the central nervous system. It's a little bit more protected. Okay. The axon fragment here at the top here, okay, so you can see that it's cut. Okay, and that those ends seal themselves off. Okay, so this end seals itself off, but you see all these little kind of drops happening here. Okay, so axon transport obviously is going to be interrupted, causing the cut ends to swell. Without access to the cell body, the axon and its myelin sheath begins to disintegrate, distal, further away, okay, to the injury. Degeneration of the distal end of the cut axon is called Valerian degeneration. Okay, it spreads down the axon. Make sure you know that. That's a board's question, what Valerian degeneration is. Okay. So look at the swelling happening here. Okay, swollen nerve. It needs this to repair. This is part of the innate intelligence of the body, and it's calling in the healing capabilities here. So see how the macrophages get called in to the chemistry of the inflammatory chemistry here. Okay, so they're being called towards. They move via chemoreception. They pick up on the chemistry around them. Number 2, Schwann cells and macrophages clean out the dead axon distal to the injury. Surviving Schwann cells engulf the myelin fragments and secrete chemicals that recruit macrophages, those big eaters, those Pac-Mans over there. Okay. Macrophages help dispose of the debris and release chemicals that stimulate Schwann cells to divide. Okay. Stimulate Schwann cells to divide. They're going to divide. They're going to heal. Okay. We are designed to heal. Number 3, axon filaments grow through a regeneration tube. Schwann cells release growth factors and express cell adhesion molecules, or CAMs, that encourage axon growth. Schwann cells line up along the tube of remaining endoneurium, forming a regeneration tube that guides the regenerating axon sprouts across the gap to their original contacts. You can see it happening right here, okay, right here. Number 4, the axon regenerates and a new myelin sheath forms. The Schwann cells protect and support the regenerating axon and ultimately produce new myelin sheath. This is how we know it happens in the periphery. Okay, so this is Marie Pearson view. One of the concepts of healing that we want to be aware of is VEGF. Okay, so we looked at how a nerve can heal and repair, and then we want to look at the concept of VEGF specifically in the nervous system. So VEGF promotes neurogenesis. So what this means is nerve regeneration or creation, nerve creation. Okay, so VEGF has tropic effects on the neurons and glia in the central nervous system and peripheral nervous system. So this substance here, VEGF, supports neuronal migration in the developing central nervous system. It's essential for neuroprotection in adults. And now, of course, this paper is a PubMed published paper, peer-reviewed paper. This is what we look for in allopathic medicine. Okay, it was up here. So we've known this since 2010 at least, okay, at least in this paper. It's probably earlier in other papers. But VEGF, they're saying here, may be of therapeutic value in the treatment of neural disorders. Okay, great. What is this VEGF? Well, hey, you guys, this is just a substance that happens naturally in the body when we're inflamed, okay, and as part of the normal healing response. And what are we doing here? Okay, so NSAIDs, according to this article here and what we know, right? NSAIDs are actually known to block VEGF. Okay, so the substance that we naturally make in order to help heal so many aspects of the body, cardiovascular, bone, okay? This is talking about osteoblasts. So when you break a bone, don't be taking this stuff unless you really, really, really need it. But know that this is going to inhibit VEGF gene expression in osteoblastic cells, right? So NSAIDs block VEGF, the thing that is promoting healing, regeneration, growth. The same thing they just said on the previous slide, saying, hey, maybe we could use this as a treatment. Well, maybe our body already makes it, right? It does. Our body already makes it, and we're blocking it with NSAIDs. Okay, and the treatment with the different NSAIDs significantly reduced VEGF expression regardless of the cell line and the NSAID studied. So NSAIDs inhibit healing. So what does this mean? Does this mean that maybe we should limit or really, really think about, do we really need that NSAID in order to help control our pain? We will be turning off certain aspects of healing in return for that pain relief from that NSAID. So maybe there are other ways to manage pain. Okay? Maybe that should be common knowledge and taught to everyone that, hey, you're giving up an aspect of healing by taking this NSAID. Okay, so maybe understanding the risk versus the reward on taking something simple like an ibuprofen. Okay. This is extremely important for our patients with multiple sclerosis. So multiple sclerosis, just meaning multiple scars, or basically this area here is destroyed. So technically we want to answer this question right on our boards by saying it is an autoimmune disease, dysfunction, and its destruction of the oligodendrocyte. So here, okay, so one of the things we want to think about is that NSAID shutting off that VEGF. Okay, so VEGF we know helps to repair multiple cell types. Okay, we know these things. One of the other things that we know is that Schwann cells, okay, so in the periphery, but we can make inferences to the central nervous system into areas that we're not quite sure about, or the research isn't complete on yet. But these diseases are not cured yet, so we have to keep thinking and working on these diseases. So multiple sclerosis, oligodendrocytes, okay, so autoimmune dysfunction, destruction of the myelin sheath. Well, why? What is the innate intelligence of the body doing here? So why would the body destroy myelin sheath? Okay, it's extremely important in our functioning. Well, let's look. So what we know from the periphery here is sites where axon collaterals can emerge, okay, are only at these myelin sheath gaps. Okay, so not out from areas that are myelinated, but areas where there is no myelin. Okay, so what we used to call the node of Ranvier or node of Ranvier, or these myelin sheath gaps, the only areas where these axon collaterals can emerge. Okay, so if you needed to repair something, what would you do? Okay, so your immune system might start to open this up, might start to get rid of some of this myelin in order to maybe make more collaterals, maybe repair the nerve. We like to think of this lamp analogy here. Okay, so if we did not live in a throwaway society and we wanted to repair this lamp that was broken, and we have figured out that it is the wiring, right? So maybe a rat or a mouse or something chewed through the wire here. Now you want to repair this wire. What do you have to do? You have to strip the wire. You have to get this kind of plasticky overcoat of the wiring off of it. So you strip the wire, you rewire it, and then you put your electrical tape back over it, and now you have a functioning lamp. Well, what if I came in and saw you stripping the wire here, and I said, "Hey, stop that." Right? So the lamp is already broken or on the fritz or breaking, not working the way we want it to, and now you're destroying it even more. And now I've kicked you out of the room, and now I just have this dysfunctional lamp, and now you chewed up the plastic coating around the wire because I didn't get it. I didn't know the whole picture. I didn't know what you were doing, what your plan was. Okay, so same thing here. What's the plan of the body? Why would it destroy this myelin sheath? Okay, multiple reasons why. Okay, thoughts, traumas, toxins, all the different ways that we can imagine what could be damaging this area here. Okay, but we might want to look at it this way, that the body was stripping this for a reason, because we know that axon collaterals can only emerge from areas in which there is no myelin. We also know that VEGF is required to create those collaterals. We also know that NSAIDs shut down VEGF. So it is extremely important to show this information, to tell this information to your multiple sclerosis patients. Let's say they have headaches, let's say they have pain, okay? And they need to heal. They need to have all of the abilities of their body to heal. Okay? And we're shutting them down by taking NSAIDs. It's extremely important to get this point across. Another little picture here for you. Okay, so we're just exposing the fiber here. Okay, was not exposed here, damaged or destroyed myelin, exposing the axon fiber here. Why? Okay, so let's talk about this a little bit more. So it's a central nervous system disease, okay? And we're dealing with oligodendrocytes. So see these little white spots here? They're not supposed to be here. Okay, so this is the scarring. Okay, it's just scarring on the central nervous system. It doesn't tell us why or what or how or anything like that. Okay. Just little reminders for you here from way back when in our introduction in neuroscience. So you can pause and read this if you like. We've seen this picture before as well in that very first chapter, oh so long ago. This is a scanning electron microscope of oligodendrocyte. That's that center orange attaching to an axon nerve fiber, the light green. Pretty cool looking how it does this. And just a little reminder here, okay, fasciculus, funiculus, lemniscus, peduncle tract. This is all white matter, so this is all potential area for multiple sclerosis to degrade or destroy or create dysfunction. So it's brain and spinal cord that we're worried about with multiple sclerosis, both brain and spinal cord. Remember that medial lemniscal pathway, DCML, dorsal column medial lemniscal pathway, also spinal thalamic, so we can see all sorts of sensory dysfunction because of the demyelination of the medial lemniscal pathway. A little reminder slide here for you as well. And here, so just remember, MS can affect the white matter of the cord as well, and all of the functions that you remember from Chapter 10 of Nolte, it can be affected. So myelination, okay, so myelinated and unmyelinated fibers. Why does this cute little baby here walk funny, right? So if you ever noticed, sometimes you might compare a baby walking, trying to talk, do simple functions, looks pretty similar to someone that is inebriated because of the cerebellar aspect. So the way that alcohol affects the cerebellum and the way that the baby is not fully myelinated yet. Check this out. At birth versus 6 months, a year, at about 18 months or so, they become fully myelinated. So you'll get a positive Babinski sign on a baby up until they're pretty much fully myelinated at about 18 months. Demyelination should be considered in any patient with unexplained neurologic deficits. So this is straight up from the Merck here. Okay, so primary demyelinating disorders are suggested by the following: diffuse or multifocal deficits. So when something is confusing and doesn't follow a dermatome or has no real rhyme or reason, no pathway that you can discern, think MS, because it could be these patchy little demyelination areas throughout the central nervous system that's giving you these weird looking signs and symptoms. Sudden onset, particularly in young adults. I highlighted this. Onset within weeks of an infection or vaccination. Again, the Merck saying that MS or demyelination can be a reaction from vaccination. And then the deficits that wax and wane, stuff that kind of comes and goes. And the good news when something comes and goes is we can hopefully figure out what's making it come on and what makes it come and go, and give them more time with more relief and try and figure out what the triggers are that's making it come on and how you can trigger it to leave and stay gone. Symptoms suggesting a demyelinating disorder. Things like optic neuritis. Optic neuritis is a salient feature of multiple sclerosis. If the patient has optic neuritis, I'm sending out for an MRI for suspecting multiple sclerosis. INO, this is super salient feature of MS, internuclear ophthalmoplegia, so the inability or damage in conjugate eye movement. So they're not yoked together. The eyes are not moving appropriately together anymore. Specific tests and treatment depend on the specific disorder, of course. Optic neuritis. So inflammatory demyelination of the optic nerve. It's highly associated with MS. Optic neuritis is the presenting feature in up to 20% of MS patients and occurs in up to 50% of patients with MS. This is from the Merck. If you look at other resources out there and if you talk to your MS patients, these numbers are way higher. Okay? These numbers are way higher in reality. This condition occurs more commonly in women than in men and occurs between the ages of 20 and 50. The two most common symptoms of optic neuritis are vision loss and eye pain, so pressing on the eyelid and it's painful. Signs of optic neuritis include decreased visual acuity, an afferent pupillary defect, abnormal color vision, visual field deficits, remember chapter 17, right? And reduced contrast sensitivity. 1/3 of patients have visible optic nerve inflammation on their MRIs or through a neuro-ophthalmic exam. 2/3 abnormal appearing optic nerve known as retrobulbar, behind, okay? Retrobulbar optic neuritis. And you could check out this resource here if you like. And you could see on MRI, clearly the optic nerve is swollen on this side versus the other. Clear here. Here's the eyeball, here's the nose, here's an ear, okay? And so we see a very inflamed optic nerve as compared to the other side, optic neuritis. Okay? And just a little reminder slide for you here. That's what we were looking at. Right here, optic nerve. And I put in the visual fields here for you as well. So remember the calcarine fissure? Okay, so this would, I believe this is in chapter 17 in OT from your previous class with me. So everything up, okay, is down and over here now. So look at number 1. 1. Okay. 5. 5. Okay, so what is up is down and what was right is left is what this is reminding us of. So what happens if maybe this has a lesion here? Okay? They might not be able to see appropriately because a different area of the brain has a lesion. So anywhere along those visual pathways is very important. There's a lot of real estate along that visual pathway, so a lot can go wrong. And we were talking about convergence and accommodation in chapter 17 as well. And so we want to think about this when we are thinking about our demyelination dysfunctions here. So they might have problems with convergence and divergence. Okay, so convergence and divergence. Pupillary light response can be an issue for sure. And we call it the swinging flashlight test, where we swing the flashlight back and forth a couple of times, numerous times, to see if this fatigues out. In a neuronormal person, it won't. So it will, the pupil will continue to constrict as many times as you challenge it. But in a patient with MS, this will start to fatigue out after a couple of times. So swinging flashlight test. So swinging the flashlight back and forth towards the eye. So we see this normal response over here, but we might see that normal a couple of times, like I was saying, but we might actually see the patient's pupil dilate when the bright light is swung from the unaffected eye to the affected eye. So this positive RAPD of the right eye being shown here. So relative afferent pupillary defect, also known as a Marcus gun pupil. Again, highly indicative of multiple sclerosis. Another slide here explaining it for you. You could see where the pupil here is constricted because of the light. Okay, this one not constricted, it's dilated. Okay, not what it's supposed to do. Okay, not what it's supposed to do. Okay. And just a little reminder here for you of what's controlling the pupil. Okay, so we can see our visceral motor parasympathetic efferents, or our Edinger-Westphal parasympathetic supply to constrictor pupillae and ciliary muscle. Then we see our, that's in blue here. And then you can see the pink somatomotor efferent or ocular motor innervation of all others 3, right? SO4, LR6, all others are going to be 3. So the loss of light response. Okay, so let's read through this. Loss of light response due to certain lesions. With a unilateral optic nerve lesion, meaning that's on one side, okay, you shine a light into the affected side, that's going to induce, okay, no direct light response on the affected side because the optic nerve isn't working. Okay, so you can't see. So if you can't see, you can't respond. Okay, it's just that basic. The consensual light response on the opposite side will also be lost because of impairment of the afferent limb of the light response on the affected side. Meaning, again, you can't see, therefore you can't, if you won't have an effect. Okay, so it doesn't see anything, and so therefore the ipsilateral side and the contralateral side are going to be unaffected because there's nothing to spark that response. Okay. So illumination of the unaffected side will, of course, elicit pupillary contraction on that side. So that's the direct light response. So direct being the eye that you are shining the light into is responding. Indirect would be the opposite eye. Okay. Consensual light response is also present because the afferent signals for this reflex are mediated by the unaffected side, while the efferent signals are not mediated by the optic nerve. With a lesion of the parasympathetic ocular motor nucleus or ciliary ganglion, efferent or motor, efferent limb of the reflex is lost. In either case, the patient has no direct or indirect pupillary light response on the affected side. a lesion of the optic radiation or visual cortex, geniculate part of the visual pathway, does not abolish this reflex given that it will affect only the geniculate part of the visual pathway. So what is this saying here? So remember geniculate being lateral and medial geniculate of the thalamus. Good. So lateral being L for lateral, L for light, so that is sight here. Okay. Medial, remember that was music or hearing. Good. You have seen this picture in your slides before, but I like to give a little bit of a visual so you could see the optic nerve, okay, the optic chiasm, this full visual pathway here. Okay. Just kind of a cool picture to remind you. And I hope you remember this as well. So this is the visual pathway again. This is giving us this temporal visual field of the right eye, temporal retina, and it's color-coded, right? So here's our purple, and it's crossing over and ending or landing here at Brodmann 17. Green here, okay, so this would be the nasal visual field, nasal retina, and then it stays on the same side, okay, all ending in Brodmann 17. And then we had this before, so go ahead and pause this if you need a little refresher. Okay, pause this if you need a little refresher, and go ahead and go through this. It's chapter 17, I believe, from Nolte. Conjugate gaze. So we use this one all the time. Okay, so I use this all the time in practice. This is how I'm keeping track of my patient's progress. Okay, so we are looking to see, are the eyes yoked together? Are they in union together? When you look right, do both look right at the same time? When you look left, do they both look left in unison? When you look at your nose, follow your finger in towards your nose, do they both do that at the same time? Okay, SO4 is usually going to be the issue with that one. Okay, here's the conjugate gaze. So again, review from chapter 17. And a little anatomy review here as well. So remember, we have, let me get my marker here for you. Superior colliculus is here, inferior colliculus is here, okay? And on the other side here, we can see the nuclei, nucleus of ocular motor, cranial nerve 3, nucleus of trochlear, cranial nerve 4. Okay? And remember, this is super significant, right? Because of this cerebral aqueduct connecting fourth ventricle to the third ventricle. Okay, it's so thin. And if there's inflammation in the brain, this is really going to take its toll here. Okay, so if there's inflammation in the brain, okay, we're going to see symptoms, signs and symptoms here. We're going to see cranial nerve 3 issues. Okay, we're going to see cranial nerve 4 issues. Okay, do your cranial nerve examination in order to check that out. That's how I keep track of my patient's brain inflammation. I do a quick cranial nerve 4 pre and post treatments. Okay, pretty much every visit for TBI patients. Smooth pursuit. Okay, so again, aim is to keep the object on the fovea for the greatest visual acuity of both eyes. So you saw this before. Okay. And we start to see this pathway get involved with the cerebellum. Now remember, demyelinating diseases, okay? Demyelinating diseases, the MLF is myelinated. This guy right here crosses over. This is the midline of the body, just midline, okay? It's a terrible line that I drew there. Good thing I'm not an artist and that I'm a scientist instead. But the MLF is myelinated, so you could have a lesion here. Your MS patient, very commonly is going to have a lesion here at the MLF. You're going to see that. That's a very common sign symptom in MS. And you're going to see issues with smooth pursuit. You're going to see issues with cerebellum, balance, eye tracking. Okay, VOR is great for this. Vestibular ocular reflex. Exercises are great for this. Okay, so again, midline. This is just the midline of the body. The MLF crosses over. Remember, this is bilateral and symmetrical. So we saw it on this side on the last slide. Okay. but we see the vestibular ocular reflex, so it's rapidly adjusting eye movements to head movements. This is where I jokingly call it, you can walk and chew gum at the same time. You've heard that saying before. Well, this is walk and turn your head at the same time and move your eyes at the same time and not fall over. Okay? And there's a lot of different exercises that we do in different stages for different abilities of the VOR. And it's extremely powerful neural rehab to do your eye movements with your head movements. Again, just another slide explaining this. So that lesion of the MLF and what we would then term INO, internuclear ophthalmoplegia. So don't let the words scare you. Okay, so inter, in between the nuclei. Okay, so in between the nuclei. Okay, nuclei being the cell bodies of our cranial nerves for eye movements here. Okay, and then ophthalmoplegia. Okay, so plegia, not being able to move. Okay, and ophthal eye. Okay, so INO, internuclear ophthalmoplegia. And this is just to kind of help you out here. So you could read this and fill in the blanks over here. Go ahead and pause and do this activity on your own. Cool MRI here to show you this visual pathway. Okay. So you can see obviously the eye is right here. Okay. You can't really see there it is. You can see on the left where I just kind of made it red. I'll make a yellow highlighter for you. Well, maybe not, but you can see the eye there. Right, that's the eyeball. And then we see the optic nerve coming down. Okay, optic nerve coming down right here. And then here's the optic chiasm you could see in the center. Okay, I'm kind of highlighting it here for you. And you can see this whole visual pathway. So you see the optic tract. Here's the lateral geniculate nucleus of the thalamus. Very good. And then we see our Meyer's loops, our optic radiations, and then landing at the visual cortex, primary visual cortex, Brodmann's area 17. So I'll erase this so you can see these different aspects of the MRI. Pretty cool, right? Okay, so MS, we're talking about MS a lot, right? So multiple sclerosis characterized by disseminated patches of demyelination in the brain and the spinal cord. So this is a central nervous system issue. On your boards, I want you to answer that it's an autoimmune dysfunction, okay, autoimmune disease of demyelination of the oligodendrocytes, okay? Common symptoms include visual and ocular motor abnormalities, paresthesias, weakness, spasticity, urinary dysfunction, and mild cognitive impairment. Typically, neurodeficits are multiple, with remissions and exacerbations gradually producing disability. Diagnosis is by history of remissions and exacerbations, plus clinical signs, test results, lesions seen on MRI, or other criteria depending on symptoms to objectively demonstrate more than 2 separate neurological abnormalities. So multiple sclerosis, multiple sclerotic plaques on the brain, and a large amount of varying signs and symptoms. Okay, so it's demyelinating. So it really is dependent on what structure has been demyelinated, on what symptoms you're going to get. Okay, so structure is going to dictate function here and what the symptoms are going to be. So just think of all of the places that we've learned that have myelin, right, in the central nervous system. Any and all of those could be affected. Okay. Treatment here are disease-modifying drugs that are designed to turn off the immune system. Personally, professionally, when I treat MS patients, we don't treat this way, and so we do natural therapies with pretty good results. It's always up to the patient on what they choose to treat with, and there are medical doctors that will treat with medications. But when I treat a multiple sclerosis patient, I treat them naturally, obviously, because that is my scope of practice, and we are extremely well suited for helping patients with MS. Okay, so we do an EEG project in this class as well, and that functional EEG is really crucial for getting really good detail on the issue at hand and the neuro rehab specific to it. right, some of you might be asking, what is paresthesia, right? So we just mentioned that in the previous slide, so I put it here for you. Paresthesia, right, and the loss of sensation in certain areas of the body are two of the most frequently noted disturbances in sensation. So the paresthesia definition refers to a burning or prickling sensation that is usually felt in the hands, arms, legs, or feet, and can also occur in other parts of the body. So the sensation is usually painless and described as tingling or numbness, skin crawling, or itching. The manifestation of a paresthesia may be transient or chronic and may have any of the dozens of possible underlying causes. So today in practice, I had a patient, I would call it paresthesia, where she's like, she's like, I have numbness. And I'm like, okay, can you feel it? She's like, yeah, I can feel it, but it's still this weird numb feeling without being numb. And I was like, okay. And then she was like, actually, it's like a buzzy feeling. And the way she described it was perfect, I thought, where she's like, I feel like my cell phone is in my pocket and it's going off on vibration mode. And then you look and there's no cell phone there. So that would qualify as paresthesia. Okay. So disorders that can cause central nervous system demyelination. Again, multiple sclerosis is the big one here. Okay, so you're going to see a lot of that. MS believed to involve the immune system. Okay. One postulated cause is infection by a latent virus, maybe herpes, maybe Epstein-Barr virus. It comes about every once in a while, Epstein-Barr virus, about causing MS. And if you ask me, it's maybe a spurious correlation. A lot of people have had Epstein-Barr virus. Okay, so it's a very common denominator with MS patients, but not everyone that gets Epstein-Barr gets MS. Okay, so post-viral would be a better way of describing that. Okay, post-viral. An increased incidence among certain families, okay, and presence of HLA allotypes, okay, suggest genetic susceptibility. Again, as we say, the genes load the gun, right? And the lifestyle pulls the trigger. Okay, so don't let your genes dictate your health, right? There's some genetic diseases out there, but a lot of things are lifestyle induced, and we have epigenetics. The concept of epigenetics to kind of comfort us that it's not going to necessarily be the phenotype. Okay, it could be our genotype, but it doesn't have to be our phenotype. Okay, so Bruce Lipton, concept of epigenetics, if you'd like more information on that. All right, MS is more common among people who spend their first 15 years of life in temperate climates than those who spend them in the tropics. It's vitamin D, you guys, vitamin D. Okay, so if you get enough vitamin D, there's a lot less multiple sclerosis, a lot less immune system issues, a lot less nervous system issues. Get your vitamin D. Get your vitamin D up to about 65 to 95. When your patient tells you their vitamin D was normal, ask them their number and get the blood work. Because medical normal is 35 to 100, depending on your lab. And optimal for nervous system and immune health, 65 to 95 is a better number. Some neuros go even higher. Okay, I only go to 65 to 95. I'm not afraid of higher though. Okay. Cigarette smoking, quit smoking. Okay, you want to be healthy, quit smoking. Age of onset, okay, 15 to 60 years old. Usually it's going to be your 20 to 40-year-old women would be the most common group affected. So childbearing years. Okay, women of childbearing years, fair-skinned, of some sort of Scandinavian descent. Okay, and hormonal imbalances. Okay, so period and PMS tend to cause exacerbations and onset. Neuromyelitis optica or disease, previously considered a variant of MS. It's now recognized as its own disorder. You can look at that on 783 in the Merck. Okay, and that's my dog, in case you guys were missing them. Okay, so what are we going to see? What's the pathophys here? So we're going to see localized areas of demyelination occurring. You'll see this on MRI. And we're going to see it's a destruction of oligodendroglia, right, or oligodendrocytes, remember being the myelinated cells of the central nervous system. We see perivascular inflammation or inflammation around blood vessels. This is a salient feature here. So again, we want to deflame the nervous system, right? Deflame the nervous system, protect the blood-brain barrier, protect the NMDA receptors, okay? Really the same thing over and over again, no matter what brain issue we're working with. Chemical changes in fat and protein constituents of myelin in and around the plaques. We're going to see axonal damage. Cell bodies and axons tend to be relatively preserved. So this is the Merck. Okay, so axons myelinated. Okay, so axons myelinated. We're going to see damage there. Okay, and then cell bodies are gray. Okay, you'll see gray matter on MRIs. You'll see it listed as there's destruction of gray matter. And you're like, wait a minute, I thought multiple sclerosis was specifically demyelination. And you're like, okay, so that body didn't read the book. Okay, so it just throws you for a little bit of a loop, and you just gotta roll with it. Okay, so on your boards, that's why I say it that way. On your boards, it's an autoimmune demyelination of the white matter of the central nervous system of our oligodendrocytes. In reality, anything goes. Okay, in reality, anything goes. Fibrous gliosis develops in plaques that are disseminated throughout the central nervous system, primarily in white matter, particularly in the lateral and dorsal columns, especially in the cervical regions. So you'll do a brain MRI, but you'll also do a spinal MRI. Okay. Optic nerves and periventricular areas are very common sites. Okay, periventricular and optic nerve. Okay, it's optic neuritis that usually brings a patient in to maybe the emergency room, maybe urgent care, maybe their primary care. That's going to be one of the main symptoms that's going to bring someone in. Okay, so loss of vision and pain in the eye. Tracts in the midbrain, pons cerebellum, very commonly affected. Gray matter in the cerebrum and spinal cord can also be affected. Again, here, highlighted that for you because that's the one that throws you for a loop, right? Signs and symptoms. MS is characterized by various central nervous deficits. They can have remissions and recurring exacerbations, or it could just be progressive, right? What you'll see here, again, this is the book. This is somebody trying to define things, and in reality, anything goes. Okay, anything goes in reality. And I personally don't like to put these labels on patients. Okay, so I think it's an overreach, honestly, but that's just my way of treating it. So you get to have your own opinion once you have treated enough cases and studied enough of it as well. Okay. So typical patterns of progression, you can read these if you want: relapsing, remitting, primary progressive, secondary progressive, progressive relapsing. I really just think they're splitting hairs here. So our job is to figure out what's causing it, stop it from continuing to damage our patient, and then neuro rehab to rewire through the powers of neuroplasticity, okay, and get them functioning again. Okay? It could be a mystery what's causing it. Okay, it could be a mystery that is really hard to solve, okay, but that's our job, and you'll be good at it. And if you don't want to do it, refer to a chiropractic neurologist. Okay, that's what we're there for. Refer out. Some of the most common symptoms, okay, so fatigue, vision problems, numbness, tingling, muscle spasms, stiffness, weakness, mobility problems, pain, problems with thinking, learning, planning, depression, anxiety, sexual problems, bladder problems, bowel problems, speech, swallowing problems, all sorts of problems. Remember, it depends on where the lesion is. Structure dictates function and dysfunction, okay? And here's Charcot's triad: scanning speech, intention, tremor, and nystagmus. You see those three things, you think MS, okay? You do an MRI of the brain. My question to you here, if something is relapsing and remitting, okay, the style of MS on the previous slide, what does that mean to us? Okay, what does that mean to you in regards to the ability to heal? Okay, relapsing and remitting. So our job is to figure out what caused their relapse, okay, and then how are we going to remit it or get it to go into remission? And how do we keep that remission for a lot longer? Okay. So again, you have to figure out what caused it in the first place. Okay. Figure out what the triggers are, and then get them into remission based on that. And some more here. So the most common initial symptoms, okay, are the following. So we see, again, paresthesia is that weird feeling, like I was saying, that kind of buzzy feeling that my patient was trying to explain. Okay, paresthesia is weakness or clumsiness of a leg or hand. Visual disturbances. This is going to be common in migraine as well. So you'll have to differentiate between that, okay? So optic neuritis, okay, and migraine, very similar symptom right here, signs, symptoms. Diplopia, okay, double vision due to ocular palsy or that INO, okay? And then scotomas. So here's your scotomas. Okay, so a scotoma is a blind spot right here on the right. Okay. We call this on the left a scintillating scotoma. Okay, a scintillating scotoma because it's kind of sparkly here. Okay, your patients will say, I see kaleidoscopes or rainbows, or when I get my migraine, my scintillating scotoma looks like a ceiling fan going off in the corner of the room. And then I look and I go, oh, there's no ceiling fan over there. I'm in trouble soon if I don't, take care of this kind of pre-migraine aura scintillating scotoma. So scotoma, okay, not to be confused with window where they can only see that small spot. Okay, scotoma, blind spot. So back on our topic here. So other common early symptoms of multiple sclerosis or demyelinating diseases in general. Slight stiffness, unusual fatigability of a limb. This is not an uncommon thing for you to see as a chief complaint in your office, right? So they just feel stiff. Okay? And in our case study that we were looking at, she had issues with her left leg. Minor gait disturbances. Difficulty with bladder control. Okay, so neurogenic bladder, so frequency and urgency, and then needing to void or urinate without actually having a full bladder, and then a lack of ability to control it sometimes. Vertigo, very common. Mild affective disturbances, so think mood, okay? So mood. So all usually indicate some sort of scattered central nervous system involvement and could be subtle. Okay, so if there's an issue with your nervous system, your body knows, but it can't quite put its finger on it. And that can create not only mood disturbances, but anxiety, depression, all sorts of issues. Okay. Excess heat. So this is a weird sounding word, Ut-Hof's syndrome. Ut-Hof's syndrome, okay, or phenomenon. So hot weather, hot bath, fever, or hot tub. Anytime a person that has multiple sclerosis overheats, we want to be wary of this. Okay, so may temporarily exacerbate symptoms and signs, and that temporary exacerbation or relapse or flare, might be temporary, as in a couple weeks, maybe a month, maybe longer, okay, or maybe just a couple hours. So when we're telling our patient to do yoga, yoga is great for balance for all sorts of reasons. A lot of neuro rehab just looks a lot like yoga, right? So we tell our patients to go do yoga, but do air-conditioned yoga. Do not go to hot yoga if they have multiple sclerosis or a demyelinating disorder or any of the metabolic issues in the body as well. Okay? Mild cognitive impairment, so you might call this brain fog, okay? Brain fog, or just not thinking clearly. Again, affective disturbances including emotional lability, euphoria, Most commonly, depression are common. Depression may be reactive or partly due to the lesions. And a few patients will even have seizures. And this is straight out of the Merck. This is just cut and paste from the Merck. Cranial nerves, my favorite subject, and yours, hopefully, right? So unilateral asymmetric optic neuritis and bilateral INO or internuclear ophthalmoplegia are just so typical, just salient features of MS. If you have a patient that has optic neuritis or INO, we're checking for MS. Okay? They've already probably been diagnosed with MS. Central vision is affected more than peripheral. That's what the Merck says. That's not my experience, but you know, that's okay. Optic neuritis, okay, so inflammation of the optic nerve causes loss of vision, okay, so scotomas that we saw, and we'll see again, to blindness. Okay, sometimes, as in our patient's example here, she just lost peripheral vision in one eye, okay, and it came back. Okay. Right, so abnormal visual field, swollen optic discs. Sometimes you could see that on your ophthalmoscope exam. Or a partial or complete afferent pupillary defect. Okay, is something going on with their pupils. Okay, INO or internuclear ophthalmoplegia in between the nuclei. Remember, so the nuclei being the cell bodies for the nerves. Okay, so think cranial nerves 3, 4, 6 when we think about eye movements. Okay. Results in if there's a lesion in the MLF, medial longitudinal fasciculus, connecting 3rd, 4th, and 6th nerve nuclei or cell bodies. Okay. During our horizontal gaze, adduction in of one eye is decreased with nystagmus of the other, or abducting, okay, looking away. Convergence is intact. In MS, INO is typically bilateral. Unilateral INO is often caused by an ischemic stroke. Okay. And these are just generalizations, okay? So when it comes to MS, pretty much anything is possible is what you want to know, okay? Same thing with stroke. Okay? It just depends on what structure is being affected. And then that will show us what that pathology looks like, okay? Rapid small amplitude eye oscillations in straight ahead or primary gaze, or what we term pendular nystagmus, are uncommon but characteristic of MS. So if you see that, we're thinking MS, okay? Vertigo is super common. Intermittent unilateral facial numbness or pain. Trigeminal neuralgia is super common complaint with your MS patients. Palsy, spasm can occur. Mild dysarthria. I posted a video of Selma Blair giving just a very brave and courageous interview while she's suffering with dysarthria from multiple sclerosis. If you want to check that out, you can see exactly what that looks and sounds like. Caused by bulbar weakness, cerebellar damage, disturbance to cortical control. Other cranial nerve deficits are unusual, but may occur secondary to brainstem injury. Again, it's really just about what structure is affected, and that's going to dictate function, and it could be anything. Little reminder here for you. So I have a lot of these slides in here just as resource for you, so you didn't have to look back through all of your notes from your different classes. So your 12 cranial nerves here for you, as you well know. And the nuclei. So this one might not be as familiar in your mind's eye, so I like to include this as well. So a little orientation here. So cerebellum right here, so 4th ventricle right here. We look for the circle, right? This little oval shape, we know that's the pons. So above it is going to be midbrain. We can see superior colliculus, inferior colliculus, and then we have our pons, and then we go below is going to be medulla, and then it turns into the cord. Okay. So check this out, right? So we know trigeminal here. So when you see mesencephalic, that just means midbrain nucleus. Okay, midbrain cell bodies of trigeminal nerve. That's all that part means. Okay, you can see it coming out here to the 3 branches, and then you can see the nuclei coming all the way down, and then they're just denoting this part as the spinal nucleus because this is going into the cervical spine. That's why an adjustment into the cervical spine will affect the trigeminal nerve, or may hopefully affect the trigeminal nerve because it's connected. See, it's It's great, right? You can see the little sensory nuclei here in the pons area. And then let's look. We could see Edinger-Westphal, that's associated with cranial nerve 3, right? Edinger-Westphal. So think pupillary control, right? This visceral ocular motor. And then we see nucleus of ocular motor nerve here. Okay? We memorize those in neuro for a reason, right? Because it's going to all the eye muscles except for lateral rectus and superior oblique. Remember SO4, LR6, all others, or all over 3, including pupil. Okay, great. Here's the little nucleus of the trochlear nerve. It's small. It only is innervating one muscle. What muscle is that? Good, SO, right? SO4, superior oblique. Here's trigeminal motor. We can see more. Nucleus of abducens, 6. Okay. Lateral rectus coming out. Okay. So on and so forth. So you can kind of check this out. Okay. And what would happen if there was damage anywhere in here? Right? What would happen if there was damage? We know by definition, if we want to get it right on our boards, that MS affects the myelin sheath, but then we see all these resources saying that it can also affect the gray matter, which is traditionally the nuclei here, or the cell bodies. Okay? So as soon as we learn a rule in neuro, we break it, right? That's kind of how that goes. This is just a different view. So what you see here, right, is the superior colliculi, inferior colliculi, or the 4 we call corpora quadrigemina, remember. Okay? And then you can see trigeminal right here, and you can see that midbrain nuclei of trigeminal. So just a different viewpoint here for you. This is the 4th ventricle, so what's been cut away here, these are the cerebellar peduncles right here. And so what's been cut away is the cerebellum. Okay. Right here, cerebellum. A little view here for you. And I'm just going to skip through these right here. So you can go back and go through your cranial nerves if you need a review. So I'm just going to skip right on through. Okay, so ocular motor nerve, cranial nerve 3. You can check this out right here. Okay, so remember that we look at the nose for SO4, right, when we test it. Okay, when we test it. You remember this one here? And again, these are just to give you an idea of what would happen if anything along this line might have a lesion. Okay, so cranial nerve 3 damage, we'll see lazy eye, diplopia, double vision, ptosis. What's ptosis mean? Good, drooping. Okay, mydriasis. Okay, so dilated pupil with a D here. Okay, all ipsilateral. This is all happening on the same side. Trochlear, you remember that? What's going on here? So she's got this head tilt to deal with this. So maybe your patient's not going to have this to this extreme, right? So we know that the head is going to tilt lateral bend towards the strong side of the cerebellum. It could also be this, or a combination of both, right? Or just a subluxation, or the subluxation caused because of this. So many ways we can look at this, right? So ipsilateral, same side, eyeball drifts upward and slightly out. We see double vision. Patient tilts the head away from the affected side and tucks the chin in order to compensate, and they might not know they're doing it. Okay? And then they might just be complaining of neck pain or headaches because their neck is subluxated. Okay, cervicogenic headache. Right here, okay, so we looked at this before. So PAG, what's the PAG do, right? That was the question here. So let's look. Okay? So we're looking. We see this is inferior colliculus. So remember, you hear something out of the ordinary, you turn and you look, right? That's inferior colliculus. So this is the level that we're at in the midbrain here. You can see the cerebral aqueduct connecting the 3rd and 4th ventricle. Okay. So here's the trochlear nucleus. Okay, cell bodies for the trochlear nerve. Okay, and you can see that it's right here. Okay, superior, inferior colliculi, cerebellar peduncles. And then over here, a real picture, you could see the trochlear nucleus, right? Not very clear cut. I mean, you could see it, but because we know it's here, right? But if we had to pick that out without a line there, that would have been hard to see the first time around, right? And then this periaqueductal gray, or PAG, okay, periaqueductal gray. And the question I had for you last time was, what symptoms might someone have if the periaqueductal gray were damaged? Again, gray matter can get damaged, even though we don't want to answer that on our boards, right? It's white matter, it's myelin, right? Oligodendrocytes, specifically because it's central nervous system. But if the periaqueductal gray is involved, I immediately think of serotonin. So I'm going to think of depression, mood disturbance, right? Anxiety, and all the things that serotonin does for us. So also pain suppression is key as well. Pain suppression. Okay? And that's the number one reason someone's going to come and visit us. Okay. Here's 5. Okay, a little refresher on cranial nerve 5, base, pain, temp, right? So trigeminal 5 is, we like to think of it kind of like spinal thalamic tract, but for the face. Touch, pain, temperature, it's huge. Also muscles of mastication or chewing. So when our patient has TMJ dysfunction, why? Right? Why doesn't the body just set itself straight? It's a pre-programmed stress response, like this dog growling, gnashing his teeth, telling you that it's stressed and it wants space, right? We're doing the same thing, usually one side or the other. Little refresher here. A little bit more here. So you can see it could be damaged anywhere along these lines, anywhere along the lines. You cut the cord on your extension cord anywhere along the lines, you're still going to have the same dysfunction, right? If you've plugged something into an extension cord and the cord gets cut in the first few feet or the last few or the middle, it doesn't matter. It just doesn't work, right? 6. You can see this here. So there we go. Remember these. Any damage along here, we're going to see issues with it. 7, facial, same thing. Vestibular cochlear, what if it happens at the vestibular aspect? Hearing, not usually affected by MS. Okay, but vestibular, yes, absolutely. But as you see, there's so many different structures responsible for balance, right? So it could be the vestibular nerve, it could be also the cerebellum usually, right? Or a combination of both or any of the other systems at work here. Okay. Just going to skip through these here. You could see what the symptoms might manifest as. Okay, so she had tinnitus or ringing in the ears and some balance issues, right? Motor weakness. So back to the Merck. Okay, so motor weakness, super common. Okay, usually reflects cortical spinal tract. Okay, cortical spinal tract damage. So think of the deep tendon reflexes or the misses, right? So MRS, so muscles, okay, so myotomes, reflexes, and sensory or dermatomes. Okay, so deep tendon reflexes usually increased. Babinski sign is not uncommon. Clonus present, spastic paraparesis, giving them a stiff, imbalanced gait, giving them balance issues again, right? In advanced cases, you're going to see patients in wheelchairs, bedbound. Okay? We need to help them. We need to remember this stuff. And if you don't want to specialize in this, please understand there are chiropractic neurologists that do. Okay, so they are not stuck in this wheelchair. In my mind, and in a lot of chironeuros' minds, they are not maximally medically improved just through medicine. Okay, so if they're still stuck with mobility issues or any issues, please send them out to a chiropractic neurologist. Please know that we work with this all the time. Okay, this is my specialty and near and dear to my heart here because you see the most amazing recoveries I have seen in my life and my experience as a chiropractor has come from working with MS patients. Okay. Painful flexor spasms, you know this, right? So our flexion protection is dictated by the red nucleus, remember, or rubrospinal tract. And on our boards, we want to talk about how it causes a flexion response in the upper extremities. But now we know it also can cause a flexion protection or just a protection response in the lower extremities as well. Okay? But upper for your boards. And who could forget Homer Simpson, right, with his red nucleus and his fetal position, right? Cerebral or cervical spinal cord lesions may result in hemiparesis, which sometimes is the presenting symptom. So we saw these little dots right here, little tiny dots. Okay, multiple sclerosis or sclerotic lesion, plaque, whatever they want to call it, in the cervical spine. So my question to you is this indicative of an upper or lower motor neuron lesion? All of this, upper. See how it increased. Okay, Babinski's is an upper motor neuron lesion sign, meaning that it's coming from that upper aspect. Here's a cool picture of that cortical spinal tract, right? Again, anywhere along these lines, we're going to see these symptoms, right? And it depends on where it's hit. Cortical spinal tract over here. Okay? You can see the MLF, okay, right here, this little line. MLF, and the different nuclei as well. Spinal cord, back to the Merck. Involvement commonly causes bladder dysfunction, we know that. Constipation, erectile dysfunction, genital anesthesia, urine and fecal incontinence, and it could cause all sorts of things. Okay? We went through this, Charcot's triad, SIN, okay? Scanning speech, intention tremor, and nystagmus. Intention tremor is going to be just super associated with cerebellum. Okay, ataxia. What else? Sensory paresthesias here, loss of sensation. Okay, various painful sensory disturbances or burning or electrical shock-like pains. So the example over here in this picture is Lermite sign. So a quick flexion of the neck, tuck the chin to the chest. And the meninges are just like really stuck and tight in this scenario here. There's just some inflammation happening, and we'll see them get a shock-like sensation down the arms and the legs, or some variation of that. And that is a salient feature of MS. So if you're doing a range of motion for your patient and you come to cervical flexion and they get this weird shock-like pain, I'm sending out for an MRI just on that. Okay, just on that alone, because it's such a salient feature of it. Okay, doesn't happen all the time though. So negative in your office right then and there doesn't actually mean anything. Okay, but a positive, big old red flag. Okay. Diagnosis, it's MRI. Okay, so many neurals will just diagnose it on MRI, and it's a diagnosis of exclusion. So you look for other things like Lyme's disease. Lyme's disease could be causing it. Remember, it's just scar tissue on the nervous system. Okay, so they'll look for other things, they'll exclude other things, and then come up with the diagnosis of MS if not finding anything else to call it. Okay, so they'll also do a lumbar puncture, okay, for cerebral spinal fluid, but not necessary. Not every neuro is going to do that, because why poke into something that's sacred, right, into your cerebral spinal fluid with a syringe to look to see if your nervous system is damaged? So if they already have a fragile nervous system, right, that's pretty invasive. That's about as invasive as it gets, right? I mean, brain surgery would be more invasive, but this is a pretty protected site. Okay? So I caution people on, is that lumbar puncture, is that evaluation of the cerebral spinal fluid really going to change your treatment plan? Okay? Is that going to change your treatment plan? What's the risk versus the reward? Okay? That's what we do as doctors, is we weigh those risks versus reward. Sometimes it's worth it, sometimes it's not. Okay? Okay, so you could read the rest of that. We've talked about that. So we talked about this. Okay, so checking those IgG levels, right, correlate with disease severity. So I have my patients do a food sensitivity test to see what foods they are eating that cause a spike in IgG. Okay, and you just never know. So when I did mine, mine spiked with chia seeds. Chia seeds are supposed to be a superfood, right? I'm not supposed to eat them because I create extra IgG to them. Go figure, right? Just weird random things. So you'll be hard pressed to find a patient or someone that doesn't have a reaction to some food or another, whether they're a normal nervous system or fragile. Okay. This is a cool site. If this is of interest to you, you can look at the slide share here of another presentation by this doctor about multiple sclerosis. I left it in here, put it in here because I thought this was really cool that we're able to test the metabolites now, okay, associated with it. So you can see the lesions here. Now, I don't know why this looks like a square. I don't know if they went over this to like, I don't know. I don't know what's going on there. This is somebody else's slideshow here that I thought was interesting. And then you can see the spikes of the different metabolites associated with this. Pretty cool stuff. So check that website out if this is of interest to you. Here's a couple more MRIs. See these white spots? Okay, white spots. That's the those are the lesions. Okay. Increased fluid, meaning that there's decreased structure. Okay, so the space is getting bigger. Atrophy of the brain. You can see all over the place that there's atrophy here. Okay, these are big old lesions here. So it depends on where that scar tissue is. Okay, it depends on what the structure being affected would be, and then therefore the function. Same here. These are the Dawson fingers. Okay. Cerebellum. Okay, so check out here, right? And then we kind of associate with this. So if we knocked out the dentate nucleus, dentate is associated with dexterity, right? So maybe they're dropping stuff. Okay, so maybe she's dropping stuff with her left hand and she's got a lesion on the left cerebellum. Okay, so remember, cerebellum is ipsilateral to the body, contralateral to the cerebral cortex. Okay, or right side cortex, left cerebellum, left body. Okay, I'll say that again and vice versa. Left cortex, right cerebellum, right body. And then you could see if different areas are affected, what symptoms they might have. There's some more. You can see these little plaques right here. Okay. What might happen there? And you can read these here, right? So we would look and see what structures are affected. This guy right here, large MS plaque in the 8th nerve, right? Okay. So we know that they're going to have balance issues, and so we need to reroute that balance system. Okay, challenge it and educate it in a different way. Good. Right. This guy here again. Okay. And then just kind of showing you, that's why we look at our structures so much. And then you can get into it some more if you like at this website here, if this is of interest to you. Again, just a little refresher. And then here's our deficit. So this is from Cerebellum from our neuroscience class, NOLTI. Okay, so floccular nodular lobe, if that's an issue, okay, if there's a lesion there, we might see these symptoms. Anterior, parts of vermis, posterior, medial parts, we might see these symptoms. Posterior and hemisphere here, we might see these symptoms. Okay, so look at their symptoms and then look at what those structures are and then what other structures help out with this and then strengthen that. Again, okay, midline dysfunction, gait, titubation or the moving of the body, nodding back and forth, spontaneous nystagmus, mood. Okay, remember there's a homunculus man in the cerebellum as well as the cerebrum. Okay. In the post and pre-central gyri, remember there's that homunculus man. All right, neuromyelitis optica, we talked about this a little bit. It's called Devick's disease, so you could read that. Here's the picture of the visual evoked potentials here. There's some other tests. Again, IgG antibody specific for neuromyelitis optica. Okay, IgG. Prognosis. Okay, so Merck is probably going to have a different prognosis than I would for the patients. Okay, so it really is going to depend on the severity of the disease and the commitment the patient has to doing a complete lifestyle overhaul is usually what's required. Okay. Treatment, this is the med treatment here for you. So they just shut the immune system off. Okay, corticosteroids, immune modulators, which get rid of the immune system because they see it as an autoimmune disease, an overactive immune system. It's not overactive, it's just not properly modulating, right? So like when we train police or military, okay, so they are using a weapon to, shoot the bad guy, for a very simple example. Okay. And then you've seen those training videos where like the bad guy pops up, right? The little paper pop-ups. And then they have to distinguish between the bad guy and then like a family pops up, right? Or a baby carriage pops up, and they don't shoot that. Okay. So do we just take guns away from our military and our police force, right? Loaded question right now, but do we just take the gun away completely, right? Do we disarm the immune system completely, or do we train it so it's able to recognize the bad guy and the ones not to shoot? Same thing with our immune system and our autoimmune look on life, okay? Modern medicine shuts down the immune system. We look at it and say, what's going on? Let me support the immune system properly. How do we do that? Usually vitamin D, and then getting rid of offensive factors, okay? And we'll talk about those offensive factors more. But we always just bring it back to the 3 T's, right? As chiropractors, we look at all the complexities, but we bring it back to the simplicity of thoughts, traumas, toxins, okay? So get their thoughts right, okay? Easier said than done. Get rid of toxins, okay? Heal the trauma. So much easier said than done, but that's where we always come back to when we get a little overwhelmed, right? DMDs are disease-modifying drugs. I'm not going to get into these. This is the Merck, but you can look at it, and it's just overwhelming information about how do we shut the immune system off, okay? And it's a dangerous thing, in my opinion. Okay, here they are. You could read it. Symptom control. Okay, so other treatments. Okay, so these are all a bunch of different medical treatments here. Again, notice they're not even mentioning us, right? And this is what we do as, chironeuros, right? Down here, I put a highlight in here, so I made this little thing up. It worked really well. I told you guys about this, so it's a sin, right? To have MS is what Irene Gold will give you as a mnemonic: scanning speech, intention, tremor, and nystagmus. And so what we do here when they have that neurogenic bladder hit, right, and they got to go and they got to go now. So on their way to the restroom, as they run to the restroom, have them say a tongue twister, right, because scanning speech, right? So we're going to exercise that. And then have them do their eye movements, okay, nystagmus, all of the eye muscle movements, right? And then have them running to the bathroom, and then void, continue to do your eye movements and tongue twisters, right? And then slowly they can maybe undo that neurogenic bladder, maybe, right? So I've seen it work. I haven't really seen it not work, but it doesn't mean it doesn't work, or you know what I mean. But it's nothing dangerous, right? It's not a new med. It doesn't cost anything. If it works, cool. If it doesn't work, right, keep trying. It might work later. Supportive care. Okay, so this is straight from the Merck. I'm really glad that they're mentioning vitamin D. Okay. So encouragement and reassurance helps. Okay, so thoughts, traumas, toxins, thoughts. Regular exercise. We want them going to like a physical therapist that specializes in MS. Okay, and then once they're healthy, strong, equalized, feeling great, then they can go to like a general, like basic yoga class. That would be nice, right? Not hot yoga. Vitamin D. Okay, 800 to 1,000 units daily. That's tricky, right? So we know, don't guess, test, right? That's what we say all the time. Don't guess, test. How do we test? What if they don't have access to insurance? What if it's expensive? What if you're not in network with their insurance, or they won't let you get the test? This is $50. They do it at home or in your office, depending on where you are working, right? So some states you can puncture the skin, some states you cannot, okay? So they can do a self-test, send it off to Everlywell, $50, you know your number, you don't have to guess, and then you prescribe vitamin D based on what their number was, okay? So personally, myself, I keep mine, so we know that optimal levels for your immune and nervous system are between 65 and 95, and I take 50,000 IUs once a week, okay? And I'll show you that in a little bit where I get that from, and that keeps mine at about 65. Okay. Plus, the sunshine and the food and all the other things that I do. So high levels. It seems like a lot, right? But if you were to sit out in the sunshine in shorts and a tank top on a nice day, you'd get, in about a half hour's time, you would get about a 40,000 IU hit. Okay, hands and face, not enough. You need like more skin exposed. Okay. Here, this is where we were going. So remember in the beginning when I told you, well, when we just read the Merck's introduction to demyelinating diseases, and that it could happen post-viral infection or post-vaccination. And then here it's like vaccination does not appear to increase the risk of exacerbations. So yeah, it's exacerbation versus cause, but anything that causes it can cause an exacerbation, remember. Okay? So any insult and injury, this is an inconsistency if you ask me. Okay? So different neuros out there are going to have different opinions on whether MS patients are special populations that require an exemption from a vaccine or not. I just know that conversation's out there. Debilitated patients require measures to prevent pressure ulcers, UTIs, intermittent urinary self-cath. Hopefully we're going to not see them progress to this. Again, this is their treatment. They're just going to shut the immune system off. Here's the criteria from the Merck. Okay, so it needs to be distinguished from the following. So CIS, or clinically isolated syndrome, consists of only a single clinical manifestation typical of MS. So think of it, instead of as the M, multiple, right? Just kind of think of it as like one, okay? Radiologically isolated syndrome, MRI findings typical of MS that are incidentally noted in patients but have no clinical manifestations, okay? Seems like we are just really splitting hairs here, right? Because remember our remitting and relapsing and what's causing an exacerbation, what causes it to go into remission. MS can be distinguished because diagnosis of MS requires evidence of central nervous system lesions that are separated in both time and space, so location. For example, any of the following can indicate separation in time: a history of exacerbations and remissions, MRI that shows simultaneous enhancing and non-enhancing lesions, even after patients are asymptomatic. So that's when they add in the contrast or the GAD. Okay. A new lesion on a subsequent MRI in patients with a previous lesion. Separation in space can be established by finding lesions following central nervous system area typically affected by MS. So periventricular, around the ventricles. Cortical, juxtacortical, white matter next to the cortex. Infratentorial, so remember that's going to be the fascia, okay? Fascia at the cerebellum. So underneath there would be infra, or supra would be above it. Spinal cord and optic nerve. So remember, optic neuritis is a salient feature of MS. It gets complex, so every once in a while we need to take a little break and remember, okay, so there just could be damage anywhere along the line. If it's in the central nervous system, that is indicative of multiple sclerosis. Okay. So we'll see weird symptoms, remember, okay, because pain and temperature cross at a different level than the main pathway for touch. One-sided damage affecting these two pathways could diminish touch on same side and pain and touch on the other side. How weird, right? So that's why we think, wow, this is a weird symptom. MS is going to pop into your differential. Again, anywhere along the line in the central nervous system. And then they throw in that caveat of it could actually just affect the nuclei as well, right? So, but think about this, right? What if it's only affecting right here, or here, or here, or here? Remember how small the spinal cord is, though, okay? Super small. So think about it as like the width of like your thumb. Look down at your thumb, the width there, that's like the width of your cord if you haven't seen it in lab yet. And then all the functions, right? So look at the structure that's damaged. We know the function. Okay. You've seen these before. I just want to remind you, if it happens anywhere along here, we see all of these issues could be at risk. Okay, here's your tracks again. Anywhere in the central nervous system could cause an issue. Homunculus man, right? So what if there's a lesion here at the foot in the sensory aspect? Okay, post-central gyrus. Then they would have sensory issues at the foot that have nothing to actually do with the physical foot, right? But it's the brain's interpretation. Same thing with motor. Okay, and that's this right here, this right here. Okay, anything is fair game for MS. Okay, you guys know this, vibration sense, you guys know this. I just put it in here for reference sake here for you, so you get the idea. Anywhere along these lines, balance, vestibulospinal, okay. Anywhere along these lines. There's our good old Homer Simpson, which might be how you're feeling right now. Okay. So just go on back into your anatomy. If you know anatomy, right, you know what these different structures, what their functions are, you can help this patient. Okay, so what do we do, right? So what do we do with our patient? Okay, so you know how to do a SOAP for the subjective now, the history of present illness, or the HPI. So that's our MOP Corsta, okay? So, or our LMOP Corsta. Okay? We do an orthoneuro exam, of which you will learn. Maybe, right? So we're like, hey, we think this is MS. Send them out for an MRI. Maybe they don't want to pay, the insurance might not want to pay for a chiropractor's recommendation of an MRI, so you might need to co-manage with their primary care physician or a neurologist. It's usually quicker and easier for them to get into their PCP MD than a neurologist. Neurology appointments can take a while, so just understand that part of the system. Perhaps refer out to a chironeuro if you're not comfortable treating. Okay, we treat this, chironeuros treat this, right? Or co-manage, or would be a good thing to refer out to. Plan. You do your neuro rehab that you're learning here based on your specific findings of your exam and what the MRI says. Okay, so currently there's no cure for MS. Okay? So it's really hard to create a treatment plan of saying, hey, you're going to be better in 2 weeks. Hey, you're going to be better in 2 months, right? There's no cure. So nobody really knows how quickly or how slowly or what exact recovery you're going to be able to achieve with them. Okay? But many people have found relief and are thriving doing natural therapies, okay, which include traditional chiropractic and especially chironeuro. Okay, so we need to understand brain anatomy, our rule of fours, cranial nerves, of which you are experts at by now, eye movements, the MLF and the tracts, okay, so medial longitudinal fasciculus, you know that, and then our cranial nerve exercises, of which you've done those exercises last term or the term before whenever you took neuroscience with me. You did a video of that. Our vestibular ocular reflex exercises, which kind of look like the cranial nerve exercises there, right? And our cross crawls. Okay, so cross crawl patterning, how did baby gain balance in the first place? They crawled, right? And if they didn't crawl before they walked, we have to do cross crawls with them and kind of wire the brain that way, or they might have problems later on in life. On here, I put the objective. Okay, so for our example patient, this is not a real patient. Okay, I found the picture on the left online. But on month 4, MRI demonstrates new 2-centimeter lesion on the left cerebellar hemisphere and a high signal on flare and a speckled pattern of contrast enhancement post-GAD image. So GAD is the contrast, that's the enhancement. So they do an MRI without contrast first and then with contrast to see if something kind of lights up more. Okay, it tells you if it's active or not. Okay, so this being the goal for this one was just that you saw the picture, right? And this is quite obvious that it's in the left cerebellar hemisphere. Remember, the rights and lefts are switched here on this image. And then the idea would be, what would happen? Okay, so she was having left-sided issues, right? So her left leg was having problems. So remember that the cerebellum coordinates with the same side of the body, but the opposite side of the cerebral cortex. Okay, so in our example, this might be what her MRI looks like. And then just showing you here different things that might be affected. So we do cerebellar testing. Okay, so we'll do some cerebellar testing. We'll look at gait, heel to toe walk, like walking on a tightrope. Okay, heel to toe. Single leg stance, as we're demonstrating here in yoga club. And heel to shin is an exam. Romberg's test, rebound test, pass pointing, pinky to nose. I'll remind you at the end to check out the Cerebellum lab that you watched in neuroscience lab that shows all of these beautifully. This is another reminder that you saw already in neuroscience, but cerebellar lesions and cerebellar symptoms here: assynergy, ataxia, decreased muscle tone, intention tremor. Always remember that. So we'll see it with our patients, and it's also a really good boards question and a good final exam question. So it really hits the trifecta, right, of boards, clinical relevance, and class. Okay? Rebound, he's exhibiting rebound phenomenon here. Lack of coordination, uncoordinated sequence of movements. Okay. Truncal ataxia, maybe they can't sit upright. So you can read the rest of this, so on and so forth. But what you're going to notice is, that's important right here, you're going to notice that your patient is going to be standing with a wider stance. Okay, so check out your balance. When you stand with a wider stance, your balance is better, right? If you bring your feet all the way closer together, your balance, it's easier to push you over. Think about sports, right? They set up with a wider stance, so it's harder to push you over. Okay? So when you're doing your balance training, keep that in mind, right? So you'll do it in the beginning with their legs a little bit further spread apart so they get the idea of it. And then as you work to increase and advance the balance, bring their legs closer and closer together until their feet are touching. Okay? It's going to be a more advanced move. Lateral dysfunction of the cerebellum, and you'll see these symptoms with lateral structural dysfunction. Okay, so a jerky, irregular movements, broad-based gait again, hypotonia, dysarthria, dysmetria, dysdiadochokinesis, or DDK for short, and that's that rapid back and forth movement. Remember, you'll see tremor, again, impaired check and rebound, impaired spatial cognition, and affective or mood disturbances. This is my sheet that I use. Okay, so my exam form here, kind of keep track of these different tests here. Okay, so a little side note on the side there: stimulate the weak cerebellum side and the contralateral cortex side first, strengthen that first, then equal therapies once it's balanced as maintenance care. Okay, so here you would look at head tilt, Romberg, single leg stance, gait, watch them walk, heel toe walk, toe walk. Heel walk is going to be L5, remember, and toe walk is going to be S1. I just throw that in there right then and there because it's easy to do and makes sense to put it there. And then heel to shin while they're sitting. And then you can mark that it's normal, or you can mark that the right is weak or the left is weak. Or if you want to put strong there as well, you could. Right, so make it your own. You could also put normal and then right weak. You could put both. Okay, so it could be normal technically, but you'll notice a slight difference. Okay. Eyes, so fixation instability, eye movement, so that cardinal field of gaze that you'll learn in orthoneuro. Convergence and divergence, we've gone through that. Flashlight or light reaction, pen light reaction. OPKs, optokinetics. Saccades, anti-saccades, pinky to nose, pass pointing, rebound, drift, and then your cranial nerves, which would take up a whole lot more space than that and have its own exam forms, right? So you can do these exams and then kind of check off and see which side is weak. Okay. So what are we doing here? So functional neuro exam, so cerebellum cortex test and localize the site of weakness. Okay, so watching that video is important here. So you guys watched that a week or two ago, depending on what day you're watching this. Stimulate, again, weak side, strengthen that first, okay, and then equal it up. One of the things to note is the head tilts towards the strong cerebellar side. We sway towards the weak side. Okay, so like in a Romberg's test or in a single leg stance. One of the notes here, It would be that if you want to do some cortical stimulation therapy, you do a scent to one side. So if you want to stimulate the right side, so let's say her left cerebellum is weak, you want to stimulate the right cerebral cortex, because that correlates, it's contralateral to the left cerebellum. So you would put a scent under one side. So close the left nostril, put in a scent under the right nostril, and then do your therapy. Acupuncture or vibration to the weak cerebellar side. So this, if it's the left side, do some vibration therapy onto the left leg. Okay. I like to go at acupuncture points. So even if you're not needling into those points, we can go into some of the acupuncture points. So personally, I choose liver 3, spleen 6, stomach 36, these points along the lower extremity. Okay, and then the upper extremity, I would pick points like LI4, lung 6 or 7, LI11. Those are great points to stimulate on the extremities. If you don't know what I'm talking about, that's okay. We can look over a chart of those at another time. Right. So acupuncture or vibration, you can just put a massager into those areas, or grab a tuning fork, hit the tuning fork, and vibration into those areas. So like if you're putting vibration into that, what part of the spinal cord, what tracts of the spinal cord are you stimulating? Yeah, dorsal columns. If it's the lower extremity, it's what? Good, fasciculus gracilis. Upper extremity would be fasciculus cuneatus. You got it. Good job. Pulse ox. That's the pulse ox over there. So don't push them past their sympathetic or metabolic rate. So you put the pulse ox on them, and you want to keep their pulse and their oxygen pretty steady. Okay, so you technically like 95 is normal, but if they start off at 98, 99 oxygen sat, and they start dropping to like 97, 96, 95, I'd stop right there. So don't wait for it to go lower, right? Just stop right there, give them a break, give them something to focus on, to chill out, relax, give them some water, and then you can go again depending on where you're at in the therapy. Okay? Or maybe you stop for the day. Okay? That's where you use your discretion. And pulse rate as well. You don't want that pulse rate going up either. Okay, so the heart rate going up is telling you there's something sympathetic going on, and we've pushed past that sympathetic, that autonomic range, that metabolic rate that we want to kind of keep. Okay. So really nice biofeedback. Those pulse ox, they're pretty cheap in comparison to a lot of the other biofeedbacks out there. So really easy, and it's part of your vitals, right? You already have that to do your vitals. So localize to the cerebellum and cerebrum. Again, you watched that video, hopefully, so you can watch that again until you get it, right? Always bringing it back. We're chiropractors, right? So we bring it back to the 3 T's that Palmer talked about when he first started teaching chiropractic. So the 3 T's: thoughts, traumas, toxins. I also like the 5 essentials. They kind of bring it up a notch. So they go off of the 3 T's that we've already talked about, but there's a Max Living group here calling out the 5 essentials. Okay, so chiropractic, nutrition, mindset, oxygen and exercise, and minimizing toxins. And I put the link there if you want a little bit more information on that. But it's basically the 3 T's taken a little bit further and a little bit easier to give patient education on. So we want to prep our patient for a neuro reset. Okay? So we want to prep them for proper neuroplasticity. So as we talked about before, right, we need to get them off of NSAIDs. We know why now, right, because of its inhibition of VEGF, and we need VEGF to help repair the nerves, right? So even though she's in pain, she's taking these NSAIDs for pain relief. We need to fix that, right? We're not going to get good neuroplasticity while on this. We still do this. If they can't get off of the NSAID, we don't say, oh, well, can't do it. No, we still do it. We just have to manage their expectations then and tell them it's a higher degree of difficulty and explain why. Okay. The blood work that I like to do. So this CWP is called a Comprehensive Wellness Profile, and that's at directlabs.com. I've mentioned that before, and I've mentioned it in this presentation as well. You can order it not on directlabs.com, but you can see what that looks like there. Okay? And hemoglobin A1C, going to tell you what their blood sugar has been over the past 3 months. Tells you a good level of inflammation, okay, how much sugar they've been consuming, because sugar is super inflammatory. HSCRP, or high sensitivity C-reactive protein, same concept. We're looking for inflammation here. Vitamin D, remember we want to see it between 65 and 95. With our MS patients, this is non-negotiable. If we're going to help them, they need good vitamin D levels. I like to do a food sensitivity test, so I've already shown you why, because of the IgG component. So we want to lower IgG, right? And some foods, for whatever reason, will spike IgG, and we don't guess, we test. Okay. All right, that's just me, so don't worry about that one. Check with NN and CC, so that's my natural neurology. Don't worry about that. That's specific to me. And get patient off NSAIDs because it's inhibiting myelin repair and formation. Supplements that I like. So I personally take and recommend and used to sell in my office orthomolecular, and they have a multi called alpha base. You could use whatever you like. Just make sure that you research it and make sure it's a high quality supplement. This is just the one that I decided to do. There's one with and without iron, and you base that off of their blood work. Okay. Methylated B vitamins are extremely important, so you add them in until remission is achieved, and then the multi has enough methylated B vitamins once they're kind of stabilized. Vitamin D, again, get them to 65 to 95. Test, see where they're at, and then prescribe your vitamin D accordingly on how low they are or if they are just maintenance. Calm magnesium sleep formula. You'll be hard-pressed to find an MS patient that sleeps well, deep, and restful and restorative. I really like collagen with MCT for repairing so many different things in the body. I like all my patients to be on something like that. Green juice, of course, for repairing tissue. A probiotic, because your gut-brain connection is extremely important. And the Paramart, or the Candida Cleanse, that is going to help balance the flora of the gut. So you want to kill off the bad guys, as we say, and then repopulate with the good guys with things like probiotics or fermented foods. Water. Talk to them about water. You'll be surprised how many patients in general are not drinking enough water. You know the equation is your body weight divided by 2. That's how many ounces of water you need in a day. So make sure that you are encouraging that. DHIST or Sinotrol is a blend from orthomolecular. It's a really great antihistamine, anti-inflammatory combo. Pick whatever company that you like and find something that works. Okay? Boswellia is frankincense. It's a really great anti-inflammatory as well. Those are common in natural anti-inflammatory mixes. I'm a huge fan of Chirothin Cleanse. So you can look up Chirothin. It's a really good weight loss program that you could sell through your office. It's doctor supervised. It's only prescribed and sold to chiropractors. So it's a nice little reset for the patient to return to healthy eating. Reduce toxins, that's one of our 3 T's. You want to encourage them. When you took physiology, we went through this in one of the labs on the toxins in soaps, lotions, makeup, fragrance, candles, things like that. Any of the hormone disruptors, you want to knock those out because there's a hormonal component to multiple sclerosis. And then Epsom and baking salt baths, but watch out for that Uthoff reaction. Remember, not too hot. Okay, but Epsom salt and baking soda baths are really nice for anybody really that's having any musculoskeletal issues or just after an adjustment and they haven't been used to an adjustment or a workout lately. So hopefully it helps them not get so sore. Here's the vitamin D I like. You could check it out if you like or not. This one here at the bottom, orthomolecular, that's going to be the wholesale that I recommend that you guys check out all the wholesales for the different brands for you. Maybe start to get an account. Okay, and then I just put mine in here so you can kind of see how I have it listed on my website. Okay. You want to get it up quickly. I use this one. I personally use 50,000 once a week with a healthy fat for absorption. Remember, A, D, E, and K are fat soluble. So you're going to need a fat in order to properly absorb this vitamin. Always, we are chiropractors. We adjust the subluxations, consider the sympathetic reaction and the cause of it. So go from head to toe, right? I actually go from toe to head, right? I go from the bottom up. You want to adjust the extremity. So on this patient, she has left cerebellar issues. I want to stimulate the left side. I want to overstimulate the left side, okay? I'm going to adjust or just motion palpate the talus, the toes, the foot, the knee, the hip, okay? All the way up the arm as well. So fingers, wrist, elbow, shoulder. I'm going to really get some good mechano-proprioception into that left side. And I'm going to leave the right side alone unless there's an injury that they're dealing with, okay? Things to consider. So what tracts and structures are you stimulating? If you add in vibration to lower extremity, we went through that. Temperature changes to an upper extremity. What happens if you have them with their eyes open or eyes closed? Okay, what's going on there? Scent in one nostril, earbud in one ear to stimulate just the one side. Have them do their exercises with one eye covered, right? Think about that whole visual pathway. Vibration sense, plus one eye, one ear, one nostril. These are more advanced. Don't start a patient like this, okay? And keep a pulse ox on them so you can see when they start to get overwhelmed, okay? And then back off. Go slow. Slow, steady, gentle is the name of the game here with our MS patients. Okay. So I found this paper. I thought it was kind of cool. A home balance exercise program improves walking in people with cerebellar ataxia. Okay, so you can read this paper if you like, but just the basics here. Physical therapy intervention is a primary treatment for gait ataxia. So they don't really have a lot of papers out there that are like chiropractic neuro rehab is helpful for MS. So we have to extrapolate. We have to see what's out there and then take that little leap of faith. That's what evidence-based is. So it's not only doing what there's exact evidence for, but it's basing your next step off of the evidence base that you have. Okay, so this is the base, and then we take that next step because we're physicians and we want to help our patient, and it might not be cured yet, and there might not be PubMed papers out there on the exact recipe on how to do that, but we can base it off of the evidence. Okay. So physical therapy intervention is primary treatment for gait ataxia and imbalance in individuals with cerebellar damage. Our aim was to determine if a home balance exercise program is feasible for improving locomotor and balance abilities in these individuals. And then they give you a really nice list of what they did. So you can make up your own if that's your specialty. Right, so I'm also a yoga teacher, so I do my own routine with my patients and for myself. And you could use this for sports. You don't have to just use this for MS, right? So you could just use this to keep your brain balanced. All of us are going to have a weak side and a strong side. It's just how subtle is it, right? And just in general, our elderly population, this is going to be one of their main concerns. About half of our population is going to be over the age of 50, and one of our main concerns is balance. So you can really bring this into any demographic, right? So you can see the seated and stable surface part here. Okay, so your patient that's in a wheelchair maybe. Seated dynamic surface, right? So like sitting on a ball or a balance board, tipping board, yoga disc. Standing, stable surface, progressing to a foam surface, okay? And then stepping and stooping. Okay? I like balance boards. You can make your own balance board. It can be cheap and easy, or you could get real fancy. Anything that's just going to kind of challenge their balance. Okay, so you can kind of go through these exercises here. Do it on yourself. See how it feels. Okay, start really stable. And kind of work up and see how it feels. It's going to be beneficial for anyone and everyone, right? As long as you find like your balance challenge. So mine again, okay, so I do my neuro exam. I include that BFAF that I've shared with you before. There's that PDF that's fillable, and then you just plug right into the form that we worked out before, and then the answer key. Just go off the answer key and prescribe them the neuro rehab. You could do it in your office, or you could have at home exercises, or you could get your CA or a physical therapist assistant or your front desk person multitasking as a lot of us do in the beginning, right? And have them run through some of these exercises with them, either doctor supervised or unsupervised. Okay. Blood work, went through that. There's the direct labs link. Diet is extremely important with MS. Okay, extremely important. I go for the deflame diet, anti-inflammatory diet. There's OMS, there's WALS, there's all sorts of different diets out there for MS. You could check those out if you like. Here's one here, foods to avoid if you have MS. It's basic stuff like no gluten, no dairy, no inflammatory foods, no junk food. Okay, so super healthy. You want to repair the nervous system, it takes work. Okay, and again, our food sensitivity, an MRI. Have them bring in the images. Read the actual images of the MRI and see if you can't determine the specific structures that are compromised in the brain and the cord. So maybe it's all over and you can't get that specific, and that's okay. We start off broad-based therapies. But maybe there's just a couple lesions in a couple of very distinct places, and you could be even more specific with your care. Right? That's what we're about in chiropractic. Very specific adjustments, very specific neuro rehab. Okay. Massage, acu, chiropractic. I don't like to go alone on just chiropractic with patients like this. I like a multi-level approach. Okay, massage, acupuncture, chiropractic adjustment, yoga, neuro rehab, everything. And the kitchen sink if I had one, right? Neuroacupuncture, specific to the deficits of neuro rehab exercises, including neuro-organizational technique. Now, we're not getting into these because it would take a whole, another year of courses to kind of understand these things. I just want you to know there's more to the story and more to be done. Okay, there's always more. And if your patient isn't responding, refer out to a chironeuro. Please refer out to a chironeuro. Okay, so there's so many people thriving under natural methods here. Of course, they need to also, you need to refer out to a neuro MD for an opinion, okay, to do your due diligence. But please note that there's more to the story than just meds. So here is the link to the basics from US News talking about those basic 5 foods to avoid that we just went through. There's also WALS, OMS, here's the words for it, so you can look those up and help people with it. Or I just subscribe to the deflame concept. So you can look at deflame.com, look at all of the research there. And it's basically just anti-inflammatory paleo. That's what I use for myself. Just as normal health, and what I recommend to every patient and every person, whether there's neurological issues or not, but especially if there are neurological issues, especially multiple sclerosis patients. Okay, so good for everybody, including neuro patients. So what do? We're going to do some balance training. Crossing over the body in a figure 8 symbol is a really great cerebellar rehab. Crossing over, like we can see over here in these yoga poses, really great for balance and coordination. We use agonist-antagonistic mechanisms in order to help with spasms. Okay, so that's what this is talking about right here. Okay. So like you fire off your quads in order to get the hamstrings to release, kind of thing. Okay, so agonist antagonistic relationships. Do your cranial nerve exercises. Do these exercises with eyes open and eyes closed. And then we want to do our Brodmann exercises with the EEG. So we do a functional EEG, and we take a look at what specific parts of the brain are functioning and what aren't. And then we look at that Brodmann's sheet here that is, you can print that out, you can save that, you can have that forever in your practice, and do the exercises that the EEG is telling you are of areas of deficit. Okay, extremely beneficial for your patient. Okay, so you can do these variations, okay, on their roughest days. You could have them seated doing different right-left activities. Okay, you can have them laying on your table doing right-left activities. Modify it for your patient on what kind of day they're having, if they're having a rough time or not. Okay, the end. That's all I got for you on this subject here. Message me if you have any questions, comments, concerns, and here is our resource or citation slide here. Again, really love these videos. I know you watched them already in NOLTI, in Neuro Lecture and Lab, but I think it's a really good time to watch them again. Okay, so it's extremely helpful to refresh. All right, message me if you need me. I'll talk to you soon in class.